So I really hope people show up today because this has really been a really good episode. Oh my God, you you guys came back. Oh God, glad you came back because honestly, we bake so many cookies that like we can't eat them all, and we're glad we have an audience to share with. So
Yeah.
yeah, it's great, and I'm really glad that you're back. So that being said, who is ready for some over the top coding discussion? Topic tonight
I'm
is
in for. I'm here for it. I'm here for the party.
that's right because you're chained to the desk. You're not going anywhere. Same with
Nope.
you.
That's
Yep, that's
right.
right. The topic of discussion tonight is going to be the one medical specialty that Jen knows that makes my face, body, soul hurt. Orthopedics.
I
It's
know.
kind of an inside, yeah, it's kind of an inside joke that those of you that know me that know that I cringe at the thought of the act of coding orthopedics. But it's mostly without due cause. It's a mental thing. So I brought in two others that will show you the loving side of orthopedics that I rarely get to
Loving
see.
son. Yeah. 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 I'm here because and I love Ken Rosenstock. I mean, like a huge
Thank
fan,
you.
and to be in your
Thank you.
presence is an honor. So thank you
Thank
for
you.
inviting me along
I
with
appreciate it.
Ken to
Thank
join
you.
tonight.
Thank you.
Glad to have you. So tonight we have two panelists, Dr. Kenneth Rosenstock. I almost said Kennifer. Bad idea. Kenneth Rosenstock works for ExamWorks, and he will be discussing the clinical aspect and the expectations of productivity and skill set from his perspective as a clinically oriented coder. Now, this is something we don't get to see every day. We don't get to see somebody with the letters DR in front of the name coding. So he's going to give a little extra advantage to the discussion. And of course, we have Miss Jennifer McNamara, who you know and love from our first episode. She's of Healthcare Inspire and is one of the top experts and consultants in orthopedic coding. And she will talk about advancement, skill set requirements, and how to improve yourself as a coder in this specialty. I, of course, will be filling in with my own orthopedic nonsense, as I also code pediatric orthopedics. But you should really pay attention to what the words that come out of Jen and Ken's mouth. So let's start with the basic question. What does orthopedic coding entail? And what are some of the common conditions treated and common treatments given?
Go
Whoever
ahead,
wants
Ken.
to go first. Yeah.
Well, I think if we're gonna start with that realm, we kind of look to the beginning, which is evaluation and management.
Mm-hmm.
So
Yeah.
that's kind of the building blocks for how orthopedics moves, and then from there we move toward X-rays that are usually taken in an office setting, and then from there it goes more toward reviewing of advanced imaging that may be done outside, or some practices have within their umbrella advanced radiology, such as MRIs. And then obviously it works from there toward a procedure-based system. And that may include office-based procedures, and it may move on to hospital-based procedures. And obviously what we're talking about here is just on the elective side, because obviously orthopedics also encompasses, by and large, emergency room trauma and anything that goes on in the hospital, from an inpatient, even on an outpatient basis, procedures that are done. And then obviously things can also be performed in an ambulatory surgery center setting, and a lot of practices have that under their umbrella too. And many of these practices also employ other specialists. They can be multi-specialty and include pain management, rehabilitation services, physical therapy. So there's a lot that it covers. It's not it's kind of a building block from the base start of evaluation and management.
I 100% agree. And, many specialties, actually, believe it or not, when you really look at them, they cover a wide range of the code book because there's so many different service lines that most specialties touch. And orthopedics is no different. But, I worked in a practice when I first started. That was your simple, basic practice. My physician did generally carpal tunnel. He did the joint replacements, shoulder, arthroscopies, things like that, the basics, right? And then typically for other things, maybe there was more complex, he would have to send them out to a specialist. Then you have your larger practices that have it all. And they kind of want to make sure that when you come to their clinic or their facility, you can go anywhere in that facility and get taken care of, regardless of what it is. Their imaging's there. They have a PTOT. They have podiatry in some cases, you know, and a lot of podiatrists too, you know, they go and maybe take that extra step and become foot and ankle specialists as well, where they're not just treating the diseases of the foot, they're actually going into the actual bones and joints and all of that. And so you have different levels of education of your physicians, different levels of specialty that they can do. And so you want to know, okay, I'm going to go into this clinic. What services do they offer? And again, what do I know about orthopedics? And, you know, we'll get into, of course, discussion on, of course, what coders really need to really know to be successful.
Right, and I think that it's very important to kind of break down a little bit of what we're looking at diagnosis-wise. The bulk of what orthopedics treats is chronic repetitive injury, acute injury, strains, sprains, or even arthritides, congenital abnormalities. There are many you know, parts to orthopedics that are incorporated into these practices, and they are primarily a referral-based specialist. So a lot of people are sent over from a primary care doctor or from another specialty where they need more, you know, focused treatment with the goal of trying to get them better. And like you said, Jen, that can incorporate physical therapy, and you know, a lot of that is also pain management. It involves spinal injections, epidurals, transforaminals, these kinds of things that also play in. So it definitely brings in a whole host of entities.
It does. And you know, I remember back when ICD-10 was introduced to us back in 2015, I was in orthopedics at the time. So I was super excited. What's going to happen with this specialty? We were told that OBGYN orthopedics were going to get the biggest hit as far as the amount of codes we're going to get. And unfortunately, still there are codes we don't have that I feel like we should. So it's such a vast landscape of codes that you have to work with. And so you got to get organized. And you got to get good on what we're going to talk about, of course, anatomy. You got to know that. So,
yeah. So you mentioned earlier that there were a lot of different types of orthopedics. Can we dive into that? Because I know there's like a lot of medical specialties have like smaller niche fields. So like orthopedics is no different. Like, what are some of the big ones, and what are some of the ones that like, you know, that are even like a small niche within a niche? Like, you know, people that code, like, I only code for the middle finger. You know, we see it broken a lot. It's overused.
Yeah, well,
you know,
well, I will say the one that I spent a lot of time that I actually, one of my passions is orthopedic spine. Like, that's one of my favorite things to code. And usually when I put on the Bone and Joint Summit, I'm like, I'm taking spine because it's my favorite. But that's one that you'll find where you have that niche because you have obviously what your neurosurgeons are doing. But there's very unique work done on the spine in those bony areas where the orthopedic surgeon is working on the musculoskeletal area of the body. And maybe they're going to also work within that joint space again. Maybe you're going to work in the 60,000 series codes in the lamina area, right? But you're still going to perform the arthrodesis procedure. And sometimes those are done together for various reasons to prepare the inner space. So those are things that you deal with in that specialty alone, that it's its own niche where you have your own, maybe there's one clinic that's all they do. It's one example.
Right. So what we see a lot of times is where patients are directed to specific surgeons who are fellowship trained in spine and joint diseases. And what happens is if there's a hand issue, like you said, carpal tunnel, then they're directed to the hand surgeon. And then obviously if it's a foot problem, it may go to the podiatrist. And the same thing for an extremity surgeon. There's one that only does knee replacements. There's one that only does knee and shoulder arthroscopies. So, you know, these folks are very highly trained and highly specialized. So for each one of these specialists, in many instances, you have a specific coder who just codes for them, who just does their inpatient work, who just does their outpatient work. And that's why they become so highly specialized in working with these folks hand in hand, side by side.
Yes.
So what you're saying is basically there could be coders out there that maybe only use 10 procedure codes and 10 CPT codes or ICD-10 codes like kind of routinely, and that's all they need to master. So like there's a possibility
in
that
some
they could
cases,
yeah, Some cases, not
So-
I
always.
wouldn't say
It can
look,
get
10's
wide.
a low number. 10's a low number,
that
but I
sounds
get where you're
low.
going with that. I get where
Right.
you're going with that. But yes, a limited amount of codes that you would use on a daily basis. You may have some that are thrown in there that you maybe have never seen before, because you never really had to deal with them until this patient came along. But yeah, like podiatry, foot and ankle, there's probably a handful of codes that I would use regularly. On the surgery side, the actual fractures can just be endless, it seems like. But when it comes to just basic, other procedures that they do, there's a handful, yes. On the arthroscopy side, the shoulder, yeah, there's a handful of codes for the shoulder, a handful of codes for the knee. If you're doing the scope, if that was your approach, they have the open side. So that's another thing too, is, you have to have an understanding of the approaches that your surgeons do, because not all of them like the same approach. My surgeon, he didn't do arthroscopy on the shoulder as much as another one I worked with. He did things more open on the shoulder.
Right.
And then on the knee, he did scope. So it just depended on what their technique is.
Right. And that can also be in a combined fashion, Jen, where, you're doing a biceps tenodesis open, but you're doing the shoulder itself arthroscopically. Yep. So it could be a blend of both, but you got to understand as a coder that there are different approaches to this. It could be open, it could be endoscopically or arthroscopically, and it can be percutaneous, where you're just making a pinch through the skin. So that's very important. It isn't just, though, for that. We also have to consider how, you're the spine expert, yourself, so you understand that when you go into the neck, you may be going in posteriorly, you may be going in anteriorly, and there are different codes for each. And it's the same thing with a combined. You may be going in both anteriorly and posteriorly in the lumbar area. You could be using a posterolateral posterior approach. So all of these different approaches have different codes that are associated with them. So it's very important that you understand that, and that's where we kind of, dip into the anatomy side.
Yeah, so and for coders out there, I would just highlight, just on a basic level, think that every code you pick and every combination code you pick has a value to it, has a fee attached to it. So if we don't get it right, we're either losing money or we're making money. So we want to keep that in mind as the purpose of our jobs.
Right. So let's go back to anatomy. Now, anatomy is one of my big headaches, because there's a lot of it. There's like 18,000 bones in the human body, I think is the last count. I think it's always growing. Like every time they update
they got a new one.
More bones. So like there's, and more bones, more codes. So like we're always like mutating into like this massive amount of stuff. So like what are some of the things that, I'm sorry, I think it's like 206 now we're at? 206 bones in the body? Something like that.
18,000 is a little much, but yeah.
But
I get you.
See, I was talking too long, and the dog is getting yippy. My high-pitched voice has awoken the demon.
Oh no! Oh no!
That was too squeaky. Sorry, guys. Sorry, audience. It'll clear up.
That's right. I got one too.
I have to shut my yapper.
Yeah. So, when it comes to anatomy on bones, I guess I would say it's a lot. It really is a lot. And so you have to get organized. And I say try to just think about the area, like head to toe, get yourself comfortable with where you're at in the body, learn it as it goes. I would start with the bones. If you're learning anatomy, start with the bones and then move into your ligaments, tendons, muscles, all that. But just get comfortable where things are. And then my biggest tip is directions, because directional terms can trip you up. Distal, proximal, medial, lateral. So, I'm sure Dr. Rosenstock can speak to more on this than me, but that's just kind of where I started was I really focused on the bones, and then I went from there.
Right. I think it's very important from an orthopedic coding standpoint, because to understand tissue planes, because what we do most of the time is we are reviewing operative reports. And in those operative reports, the surgeon is going to be talking about making dissection down through these different tissue planes, from the skin to the subcutaneous to the fat to the muscle, and through the muscle and to the bone. And this is all part of interpreting an operative report. We're not just looking for the key terms, and we certainly aren't looking at the headers. We're not looking at pre-op, post-op diagnosis and procedure to base our coding assignments. We're looking at the body of an operative report, and it's very important that the coder understands where they're working, how they're working, what their approach is, and what procedures are being done. And it's very important to, take a red pen, and then if you see someone say, well, we installed a biomechanical cage in this level of the spine, you hit it with a red pencil, and you know where you got to go get the code. You added autographed, there you go. You're going to add another code. You did an extra level, you're going to add another code. So all of these things, as you dissect an operative report, are predicated on understanding what a level is, what a segment is, and then moving from there toward code assignment. You cannot code this field without understanding the anatomy from where you're going. Look, I've never done a cervical fusion. I've done a lot of bunionectomies in my day, and I understand how it works in the foot, but it's still, you got to understand it as a coder. And I think as being a podiatrist in my past life, it gives me kind of a jump start, if you will, toward understanding it a little better. And that is absolutely not to diminish anything from Jen. She's expert in her field. She understands it too. It's not, you don't have to be a podiatrist to understand orthopedic coding. You just have to be cognizant of what's going on. And, John, I was going to mention, and in a previous thing, a previous meeting, you had spoken about what type of tools are available that would assist in anatomic understanding. And I remember, saying to myself that the Netter books are exceptional for understanding how anatomy works, and it just peels it back in a way that is very understandable. Jen, sorry, go ahead.
Oh no, you're good. No, I love those books, and I remember having one in the office. Back in the day when I was a baby coder, that was what we had, and that was what we used, and I used it frequently. Before I got into encoders, all I had was my books and my anatomy book. I had a medical dictionary, like old school. That's what we used because we didn't have encoders really that we were using then. So they're very, very valuable. And, going back to even your podiatry, your bunionectomy example, when I was coding those, there was a time where they would document by the name, the eponym, we call them, right?
Yes.
The Aiken procedure, the chevron.
Yes.
And
Yes.
so if you weren't careful, you could, when they did away with those names, I think it was 2017 when they changed that, you would have to know, okay, they're no longer called that. So what am I looking at? What's an Aiken? If you weren't paying attention to which part of the anatomy that was, whether it was metatarsal, or if it involved the proximal distal, was a double, like those things were always there, but we only associated with the name the physician documented. And then we were like, oh, wait, I have to actually pay attention to the anatomy now. And so, exactly. it was a big deal. So
one of the things that I kind of used when I made the transition into orthopedics, when I started learning, is I got a little help up in cardio, because a lot of the anatomical reference that you use for our bones are how they name the vessels. So like you have your femoral, femur,
Yep.
You have your anterior tibia. So like a lot of the reference names carry over. Your iliac, your iliac artery is related to your iliac, which is like the lower part of your your sacrum. And then you have the radial, you have the ulnar arteries, you have the brachial. So like a lot of them relate to the bone. So like if you're able to make that connection from, some work in cardiology, vascular stuff, sometimes those things carry over. Same with the muscles. Like a lot of the name muscles also relate to like those kind of vessels. Like, we have the gastrocnemius, which I think is like the longest muscle in the leg. Well, there's named vessels for the gastroc. So like sometimes these things carry over. But Google, like sometimes diagrams, I have to draw stuff out all the time when I did orthopedics, because sometimes there's they reference, just like they would be doing, if they were looking at it, like they're saying, 8 centimeters from the anterior distal portion of the proximal femur. You're like, well, what the hell does that mean? Sometimes you have to map it out. Sometimes you have to draw it out. And if it doesn't make sense to you, it might not make sense to the person reading it too. So
I love that. No, that's really important. Sometimes you do have to get out and you have to picture it. Now, not everyone can do this. Not everyone can get out on YouTube and watch it, but that was what my surgeon recommended I do, is watch it and get, actually, he was like, hey, do you want to come in the OR with me and watch it in person? And I was like, am I allowed to do that? So I went to my manager and I was like, the doctor wants me to go in surgery. I'm like, I don't know what to do. And so she's like, oh yeah, you just grab some scrubs, you'll scrub in and they'll show you everything and you'll just watch. And I'm like, okay. So I scrub in and I'm wearing scrubs, doing the whole thing, and a sterile environment. So I asked me, where do I stand? So they had me stand above the patient where I'm looking down. So literally the patient's on the table and I'm looking over the patient during a hip replacement. And that was fascinating to watch, but I had to prepare myself ahead of time. I had to watch it on YouTube because I was like, I don't want to be grossed out or like freaked out before I see this in person. And so I got to see a knee replacement, a hip replacement, and then a shoulder scope. So that was fascinating to me to see how it's done. And it did help my coding. It helped me see those incisions, that nail they pound in. Oh my goodness. I was like, I'm so glad the patient can't feel that because I can't even imagine. But no, it was just fascinating to see all that. And it did help my coding when I understood where they were going and all of that.
Yeah. I really enjoy when they do the hip placement, when they do the, they do the separation.
When they separate it from the acetabulum.
That's entertainment right there. You're looking for the pop, makes my day. Those are crazy surgeries, like in themselves. Yeah. All right, so where are we? All right, so we went over anatomy. So let's talk about daily routine. And I know, Ken, you do a lot of motor vehicle, a lot of personal injury exam work. Like you see a lot of that. So let's talk about what your day is like. What do you begin your day with, and what do you typically what do you do?
Right. So basically, I'm a unique person in the coding field because I'm not in the typical realm of a physician's office who is taking an operative report, applying codes, and then handing it off to a biller and then moving it through the revenue cycle. What I'm doing is I work for a company that evaluates medical bills for people who are injured in either vehicle collisions, personal injury, workers' compensation cases. And I'm creating reports for to assist in basically litigation resolution. And what I do is I review these bills and I review the medical records and make sure that the bills that they're submitting are lining up with those medical records. And what we're looking for is, have the providers been previously paid, either by a commercial insurance carrier, a patient, an attorney, a personal injury protection policy under a car insurance policy. And then we're determining what is left over that's entitled to these providers. And there are many ways that this is achieved. And one of it is through a national usual and customary database. And it can be through the New Jersey PIP fee schedule. It can be through Pennsylvania's PIP fee schedule. It can be through Michigan's PIP fee schedule. Florida has a PIP fee schedule too. I also do work as far as Medicare is concerned and Medicaid too. So I'm applying pricing and to these services and then making recommendations and writing a report that includes the application of coding guidelines, such as the NCCI edits. We'll talk about that, and also multiple procedure reductions. New Jersey has a daily $105 cap on physical therapy and chiropractic. So I'm a little bit unique in what I do among orthopedic coders, because I'm really more of an auditor than anything else, but I'm also working within the realm of other specialties too. So if you think about what happens when a person is injured in a car accident, you start off at the scene, you're transported from there to the hospital by an ambulance. There's a bill from an ambulance. You're going to the emergency room, you're treated in the emergency room, you're going to get a bill from the radiologist, the emergency room doctor, the facility, and anyone else who sees you when you're there. And then I follow the trail all the way through. And, they go to see chiropractors, physical therapists, they go to surgical centers. I review bills from anesthesiologists. I look at their logs. I'm also reviewing radiology reports for MRIs. So it's all to base the bills that they submit are lining up with what they're writing in their charts. And because I'm also a podiatrist, I also have a special skill with respect to writing clinical reviews too. So in my role as a coder with the company, I also write clinical summations of patients' care all the way through. And I'm even consulting ODG guidelines, which are evidence-based medicine recommendations for whether services that are done are medically necessary. I make decisions on causality, and then based on those decisions of medical necessity or causality, I may recommend a peer review to look at these services and then decide, are these services necessary? And then ultimately, I'm also working around the idea of deposition, potentially even trial testimony. So, these are the kinds of the things that go on. I didn't mean to get off onto a tangent, John, but this is kind of the basis for where my job is. And my daily work is writing these reports. So what I'm doing is each day when I clock in, I'm checking email, I'm going through medical records, I'm reviewing bills, I'm writing on another screen what my findings are, and then I ultimately sign it and then pass it along. And then it's used by others in terms of settlement purposes for folks who are injured in these crashes.
Okay, I want to ask one question, or maybe go to Jen, but I do want to ask a question since we're both in New Jersey, and in New Jersey they have a thing called PATH guidelines, and I know that is a big thing with motor vehicle and personal injury, but that's also like one of the big differences between when they have an orthopedic injury that's caused by like a motor vehicle versus something that would be a scene for like their main primary insurance. So like I think that's a good thing to talk about is like what's the difference between like who pays when, like that's a big factor in orthopedics. So let's go to Jen and then we'll talk about the whole coordination of benefits fiasco.
Oh yeah, I love that topic too. I'm all about that stuff. Well, I'm a consultant now, so I don't dig into the daily stuff. No, I do. This is just me because I like to keep my brain fresh. I do work PRN for a company that does coding for medical practices. So like I have an orthopedic client that I work with, and I just basically code their surgeries because they just need someone for that, and that helps keep my brain fresh because I want to stay fresh in that world. I do also code for ENT, so like I'll have these little projects, but I'm mostly consultant now. I do a lot of education. I work regularly for a company where I do quarterly education for orthopedics, among other specialties, for physician education as well as coder education. Really just making sure they understand what things mean, new codes that come out, how is this affecting documentation, really just helping get the documentation right. But I'll go back just quickly and tell you what my life was like when I was a production coder, because it wasn't that long ago. It feels like just yesterday. But for many years, I worked for a health system, and I was working for many orthopedic surgeons. I had like 5 that I coded for. And so, yeah, I mean, I started out, you had to have the schedule. You had to know which surgeons were doing surgery which days. I also did the prior authorizations for them. So my job was to be the prior authorization specialist. And I also did the coding because they wanted a coder doing it, because it's really important as for prior authorizations to have someone who understands the codes submitting them to the insurance company for authorization, especially with the surgical area, because it can change so quickly. You want to make sure you get all the codes in there. So I did that, and then I would follow up with the billing. I would enter the charges as well. So I coded them, I entered them. I also followed up on the billing side. I was kind of like the person that did everything for the whole revenue cycle for the clinics that I was working with. And we had backup, AR specialists that kind of worked through things, and they would send them to me if it was coding related. And I would, of course, answer those questions. So yeah, I looked the codes up. At that point, I had an encoder at one point. So I would verify basically bundles. If there was an NCCI bundle or a modifier was needed, I would use my encoder. But mostly I stuck to my book And I would have all the insurance policies on a spreadsheet or a file on a drive. And I would make sure that I remembered, okay, this is this situation. Let me see if there's a policy on this. And before too long, I started to remember that there was a policy on a given procedure. And so I would make sure that it wasn't just, I'm not just a coder. I'm also making sure that I look for the policy to say, okay, yeah, they want this claim billed this way, even though it was documented this way. Now I have a problem. So I have to go to my surgeon, hopefully now, and let them know that this is maybe an issue with payment, so they can review it with me to see if there's any changes that can be made legally, right? That can be made legally. That really they miss an opportunity here because I know them that well, and I'm like, well, I know this might be the case, but let me see if you can look at this for me. And so sometimes it was true, sometimes it wasn't, and I had to say it's not covered. So we had to make a decision there. So those are things I think that a lot of coders don't think about. Is some of you might be living in a world where you just code and you don't even know where that is going and who's touching it after you. And then others are doing the whole process and they're coding and billing, but they don't know those little nuances with the payers. And so that we're in a world now where we're at this war, right, between coders, the way the book says to code, the way the payer wants it. So there's a lot of education that needs done, which is why I love teaching. I love to share the knowledge, which is why I love doing what I do, because I've had 20 years of experience from making mistakes. Yes. A lot of my experience was making errors that I learned later why I made that error. And now I don't make it anymore because I know better. And so I can share that knowledge. I've recently got my certification in CDI, or excuse me, Certified Documentation Expert Outpatient, so that I can help practices understand how clinical documentation, how it really affects the revenue. So basically your history and exam, yeah, we don't use them anymore for evaluation and management leveling, but guess what? They're still very important, because if you can't tell us why you ordered that medication, you can't tell us why you ordered that lab or this x-ray, your clinical indicators don't match, and the insurance company is going to use that against you. So I am big in my education on clinical indicators, continuity of care in your documentation, and of course, payer guidelines.
And I think it's very important that the not even just the novice coders, but coders in general really understand this 59 modifier, because this is a gigantic issue, and it covers everywhere. I see work from all over the country. It's not just confined to the Northeast. And the big thing is just we want to get paid, and we're going to 59 every code. It's the same thing with, we're going to bill for the local anesthetic that's with a trigger point or with a joint injection.
Lidocaine.
Right. And this is something that you as a coder, as an auditor, have to understand, that you cannot get paid for that. That stuff is bundled into the price for the injection, into another more extensive procedure. And what I see, unfortunately, is that, you know, there's this push-pull of practices trying to get paid, and I get it, I understand it. But there's also the issue of, well, does the documentation support modifier 59? Or is there a hard edit where you can't bill it at all? So, you know, this is a problematic thing that is unfortunately
it's been long-term,
very prevalent.
Oh, yeah. And, you know, in 2022, I think it was, I might get my years wrong, I think it was 22, November 22, the OIG did an audit of modifier 62 and modifier 80 for the assistant and the co-surgery. And we at times did have to use that in orthopedics. And so you think about, it's the same concept. You're asking for more money. And so whether it's for your role as a co-surgeon or your role as an assistant, so you got to follow the rules. And we're seeing so many, I'm seeing so many right now where I'm like, I had to basically give no credit in my audit because they didn't have their statement that there was an assistant involved. And Medicare is very clear, and the payers follow it too. They're very clear on what needs to be documented to get your assistant paid for their work.
Right.
Why do they need to be there? Why couldn't you do it on your own? Why do you need them there present? Why are we paying them too? Basically,
Right.
that's what we want to know.
Exactly. And with this assistant necessity, you can't just write it really in your header that you had an assistant present. You have
Exactly.
to add something into the body that says it was medically necessary for this surgical assistant to be present with me in this operating room to complete this procedure in a safe manner for patient safety, basically. And obviously, when you're talking about co-surgery, Jen, you're obviously going to be looking for a second operative report, because that other
Yeah.
co-surgeon has to dictate another operative report
Yeah,
for
they're a
his
different
services
specialty.
too.
Yeah. So like
Now, there's-
spine was our example earlier, right? That's very common in the anterior part because of how they're accessing the spine through the front. So what they're looking at is, okay, usually it's a general surgeon that comes in, they do the approach, and then you have your spine surgeon doing the rest of the work. But guess what? They get paid the same. Not fair, I don't think, because the spine surgeon's doing more work, but it's a flat 62.5% for both surgeons.
Right.
So if one of you is not doing it, someone's getting paid more than the other one, and someone's getting paid more than they should.
and in the end, I think if you both do it properly, that payer usually pays out 125% of what they normally pay. So if you think of it that way, Medicare wants to make sure that it's correct, because they're not paying just like the flat rate for this. They're paying 25% more between two
Yeah.
people. So that's why they, it all boils down to what? The money. Like
Money,
they
yeah.
Yeah, so like you have to
Right,
make sure
and that is why Medicare puts out these guidelines that certain procedures are co-surgeon eligible and certain are not. I've seen it where they've built in for co-surgeons for placement of autograft and allograft in the spine, and Medicare is kind of no, you can't really, we don't have a policy on it, and there are some procedures where it's approved and some procedures where they don't give an opinion, and some procedures where you cannot do it. So, that's very important.
Yeah, those codes I think like the allowances you'll see if you're kind of knowledgeable about how to navigate the if you navigate the Medicare fee schedule finder, it gives a breakdown of like what codes allow for an assistant, what the reimbursement is. Like you really have to learn that. So that's one thing is like, I recommend as a coder for any specialty is to know how to navigate the Medicare fee schedule or that Medicare fee schedule lookup tool, because that tells you a ton of data. There's so many different.
And your encoders have that too. But if you can't afford an encoder, I always tell people all the information from your encoder comes from the Medicare physician fee schedule. It comes from that spreadsheet. Control F is your friend. You'll find it.
Yep.
So yeah.
All right. So Jen answered the question. She also opened up a can of worms I want to go back to after we talk about the whole.
Oops, sorry about that.
No, it's the whole prioritization process. I know that that is a big thing. So like all those things like MDON and all those authorization companies, that you have to be able to hunt for not only the policy for the payer, but a lot of these prior authorization companies have like their own policy that you have to look up and find before, because that'll tell you, will they likely approve this prior authorization with our documentation, or will I have to like fight? So let's go back to the question about the coordination of benefits between kind of commercial insurance versus personal injury, motor vehicle, or workers' comp, because I think those are the three big ones. I think there's a fourth one. I don't remember though. Take it away, Ken.
Yeah.
Well, coordination of benefits is something that is really more determined based on the claimant's decision as to whether they're going to put their PIP carrier primary or they're going to defer that, and then they're going to work through their commercial carrier. Now, that being said, in the work that I do, it doesn't matter who pays. I'm not making that determination as to who or why. I'm just trying to make the decision as to if they were paid, if a provider has been paid by any carrier, then they are not entitled to double payment. They can't get paid a second time if they've been paid. So if they're billing $50,000 for, say, a one-level spinal fusion, and they got paid $4,000 from Medicare, say, then they're not entitled to the difference between what they get because they've already been compensated by an insurance carrier. Now, if it's a patient payment, say it's a co-payment and they didn't receive anything else, typically what I do is I reduce the allowance based on what the patient's payment is minus what a fee schedule would allow or a usual customary database would allow. So there would be a reduction. And then obviously there are other, scenarios that work, but those are kind of the more two common things. Jen, I'm sorry, maybe you have a little bit better understanding on coordination benefits with respect.
Oh, no, I mean, that's great. Well, you have a very important niche. Before I touch on that, I want to say overall, we don't give enough attention to ICD-10 coding. And it's my biggest pet peeve is that nobody gives enough attention to it. And that's going to change in the coming years, I imagine. But that's one of the biggest triggers. So if you put your external cause codes on your claim, that's a big trigger to the insurance. Oh, wait a minute, someone else is responsible. So that's why they're so important. On the initial injury, you're supposed to, and that's what the ICD-10 book says, the first injury, the first encounter for this injury, you're supposed to tell us what happened to the patient, what were they doing, where were they at, what activity were they involved in. We want to know, because that is going to be an indicator as to we're not responsible for this. We're going to make sure that we look to see there's a external carrier that's supposed to take care of this. And that's why it's so important to have those on the first claim. Now, ICD-10 tells us you don't need it on the subsequent claims, because by that point, you're going to, of course, submit the subsequent claims to that carrier that you submitted the first time. So that's already been decided. That's a key there. Now, coordination benefits can have many issues because patients go in and out of coverage all the time. They can have secondaries and primaries flip-flop. So if they're still employed, for instance, they may have insurance with their job. That's going to be primary. Then when they hit 65 or whatever, or maybe they have Medicare for other reasons. And Medicare is going to be primary because of those reasons. There's some instances where if they're still employed, that's primary and then Medicare is secondary. And Medicaid is never primary to any other payer. Let's get that straight right now. I still see it. And I think it's usually a user error, not knowing that. They just put it in wrong and don't flip it. So that's an issue. And then my biggest pet peeve is the replacement plans, the Part C plans that get put in as traditional Medicare. It goes out, gets rejected, gets sent back, and you've just wasted that time. So again, those things can happen. I don't know. When I was in orthopedics, we had a lot of VA patients because of the physician we have a VA hospital near us. And so we had to send a lot of patients for VA. And so we had to constantly work with that Medicare if the VA was responsible and vice versa. So a lot of those things, you just need to understand your payer, understand your patient's status, their age. There's so many variables, but you need to understand it. So right. In order to know.
Right. And I think with regard to the PIP benefits, in New Jersey, there's a tiered system. It just recently passed legislature, and I'm not sure if it's gone into effect as yet, but it's moving the base minimum from 15 to 25,000, and it works up to 250,000 of PIP benefits. So the many of the claims that I see are based on the $15,000 number, and you can blow by that relatively quickly when it comes to treating injuries in relation to car accidents. So what you'll see is that when they exhaust these benefits, the patient will present their private insurance carrier credentials, and that will then start getting submitted to by the provider to pick up the slack with regard to this, because the patient still has coverage. And then obviously, look, I don't work in the office, I'm just reviewing the bills, but I don't really know why a provider wouldn't send it into a commercial carrier for reimbursement in lieu of holding a claim if they want to get reimbursed. But that's not for me to decide. I'm just looking to see if they have been paid or haven't been paid.
Gotcha. Yeah.
All right,
there's a lot to it. Yeah, for sure.
Hey, Jen, I got a quick question. Help me with this. How do you remove a user from the broadcast? I have an unfortunate soul that needs to go.
Oh, I don't know. I really don't.
Okay.
We
Then we'll
don't.
just continue. Please
Yeah.
ignore Mr. Curry. His comments make no impact on our presentation. So,
Yeah. Yeah. I
all right.
don't know.
Okay.
Anyway, so no, I agree with that. And a lot of times, you might get the question, well, how am I going to know how to know all this? You're not going to know it overnight. It's going to take time, and you may have an issue where the payer sends it back and you have to call, ask why did this happen. So over time, you're going to learn these things if you're not really up to date on coordination benefits, or if you're new in the billing world, new to coding. And so it's not something you're going to know overnight, but it's going to take time. And so we're here as consultants and educators to help you kind of weed through these things, and we can answer questions. If anyone has any questions, feel free to post them as we're talking. But yeah, it's one of those things where you just have to try your best to just walk through each scenario. Did you want to talk about prior authorizations?
Yeah, let's go to prior authorization because I know that's a big factor. Like there's basically two sets of rules, and we have to kind of compromise.
There's more than two.
Yeah, well, two per instance. I've had issues where you have to follow all the guidance for the pair. We have one in New Jersey, Horizon Blue Cross, which is the big Blue Cross in our area, and they use for orthopedics and a lot of other injury-related cases. They have a lot of prior authorizations required for spinal surgeries, knee replacements, joint replacements, and things of that nature. And sometimes being able to navigate all the rules for prior authorization are important to coders as well, because documentation is how you get things paid and how you get things authorized. Because if they're not authorized, they don't get performed. So let's talk about prior authorizations and the process for that. What should people know to expect from prior authorization companies?
Well, I mean, it depends on. So if you hire a company to do your prior authorizations, I would be very cognizant of how much they know about your specialty. Because I have worked with organizations where I've had to educate the staff on surgery, for instance, because they were so used to maybe radiology and not quite understanding the nuances for surgical authorizations are very different. You have to have a level of knowledge of that specialty and also the codes. If you don't even know, let's say, for instance, you're trying to authorize something that has a category 3 code, you're almost dead in the water because they're maybe not even give you an authorization because they may not even cover it. So then you have to have a conversation with the patient, let them know that, yeah, we think you need this. It is beneficial, but you're almost going to have to ask them to pay for it because it's not going to get covered. So you have to have those conversations with your patient. You have to make sure that there's good communication, and please don't wait until the day before the surgery to let them know it's not covered. You need to be on it because there's a whole process to this. Some payers take 2 weeks, some maybe take a couple days, some take longer. And if you just let it go and don't have a process for verifying the status of the authorization, you're also dead in the water. Maybe the patient's family's been flown in, for this surgery. And then all of a sudden, the day before, you find out and it's canceled, right? So those things can be very stressful to a patient. Then there's the process of coding it, right? Or picking the codes. Spine. We'll go back to spine. We're picking on spine tonight. So spine, you have to authorize 10 to 12 codes in a given scenario. You got to get all the orthodesis codes possible. You got to get all the grafting codes possible, the instrumentation, the cages, all this stuff, because you have to foresee the potential that might happen. A lot of that has to do with knowing your surgeon, knowing what they normally do to catch little nuances. Arthroscopy. They're not going to close the patient up if they find something and decide to do it. You have to account for those anomalies that could happen. What are your thoughts on that, Ken? I know you deal with that a lot too.
Yeah, you mentioned about category 3 codes. Look, I can't go in, with too much depth regarding prior authorization, but, you make a good point about, category 3 codes, because there's really no usual and customary allowance for them. Medicare doesn't price it. It's kind of based on similar services. So an example might be a lumbar disc replacement. There's a code for it in the cervical, but in the lumbar, I think a new code recently came out for that in 2023. But prior to that, there was not. And they would be, providers would bill in a by report only code, and because it's by report only, something like 64999, we have no way of determining a price point for it because our usual and customary database does not price it. So what we do, and this is in the PIP fee schedule in New Jersey as well, is we're looking for the nearest listed code in order to determine a pricing allowance for it, and that's what we do. So if it's done in the lumbar region, we're gonna price it. They may submit it with the by report only code, but we're gonna price it based on what it would be if they installed it in the cervical region.
Exactly. And then there's codes, I mean, I don't know how many do the Mako device, how common that is anymore, but it's never covered. And so a lot of facilities, they try to put it on a claim form and it's never covered. And like, they're not going to really, and then there's we call it the robotic code, the S2900. Like, you're trying to authorize these codes that the payers are never going to approve because they don't pay for them. And so you have to account for those, but also know that there are rules and guidelines, compliance guidelines. If you know something's not covered and you bill it anyway, that is a violation. So we still see those things happening, and it's a problem. So you may not get it authorized, but you also may not be able to bill it in general. So you need to be sure you know what you can authorize, what you can bill, and make sure to communicate with the patient.
Yeah. So again, ABNs or other kind of notifications to the patient, have them in place as well, because again, if they're not notified in advance that they may have to owe stuff, you can't collect if it doesn't get paid. There's a lot of claims that come back with that. On the EOB, it'll have an indicator, either a PR dash whatever, and that means patient responsibility. Other claims come back with a indicator that says I think it's a CO of a contractual obligation. That's a write-off. You can't say, well, insurance would pay it. That means that you have to eat that money, or eat that. There's no way around it unless you appeal.
And some patients even get billed for authorization denials, and it makes me so mad. Somebody just decided that, this denial code, it means that, okay, we're not getting paid, so we're gonna have the patient pay for it, balance bill them. And you can't do it. If you didn't get the authorization, you're dead in the water. You don't get to charge the patient. And it's a scary thought to know that there are untrained people out there posting payments that it's affecting real people.
So, and information, whatever state you're in, you kind of have to have a knowledge of their motor vehicle rules, because usually they are posted on that state's website. I think for New Jersey, like on New Jersey Gov, there's a big section just devoted to the laws around billing for motor vehicle, personal injury, and workers' comp. Every state's probably the same. So you should look into those if you're interested in orthopedics, because those rules will come up on a daily basis. So again, that's stuff that you really, really want to know and be well versed in.
Yeah, John, just to clarify, if I may, the state of New Jersey doesn't have a specific code for workers' compensation. We process workers' compensation claims based on usual and customary allowances. There's no fee schedule for them. I don't know how it works in other states per se. New Jersey has a very detailed breakout in the DOBI, Department of Banking and Insurance website, which includes all the fee schedules and amendments, and goes in very specifically with PDF format how things are to be done. And for anyone who works in the PIP realm, they're pretty knowledgeable when they treat what it is involved.
I think we also use the website for Alexa Law. Is it Alexa Law or Alexa?
Yeah, that's probably a little bit more than my understanding of it too, and it kind of breaches into the legal realm, and I'm more familiar on the PIP side.
Gotcha. All right, so let's go back to some basic questions. So let's talk about obstacles with coding. I know diagnosis codes are a big thing. I really want to get, before we end this conversation, I really want to talk about that 7th character, because that is also one.
7 character.
Yeah, 7th character is a fun one, and let's talk about that right now.
I love it. It's my favorite. Yeah, I love it. I remember the days when the surgeon I was working for, he would come back every time, and every time he saw the patient in the office, he would put a D on it. So I was like, you're still treating the patient. They're not in the healing phase yet. You just took him to surgery. Anyway, so it was just like, it was funny. You know, because I saw him last week, and I was like, well, that's true. But let's talk about what this actually means. So education for providers was huge back in 2015. They didn't really have, I think it took time. With any new guideline or any switch, it's going to take time to learn it. So the A is active treatment. Even that's what I call it. I call it active treatment, the A for active, so I know. But it's initial encounter for most fractures. That's what it stands for. And then you have your D is the healing phase, right? The fractures and healing phase. And then you have your S, sequela. So they basically had a condition, a fracture, for instance, and they come back and having a residual effect from that. Could be scar formation, some other issue happening. And so you have to know that this is currently what's happening, but then you also have to report the original fracture code with the S at the end. Those are 3 common ones. But as we know, things, are very different in orthopedics. You have extra characters that you have to be aware of for malunion, non-union. If it is a open fracture, and there's different classifications of those open fractures, different things like that. So that goes into more depth. But guess what? The book tells you everything you need to know. So if you're in the right code set, the little box right there at the top of your code set tells you all your available characters that have to be in the 7th position in order to be coded. Can't be in the 5th position or the 6th. They have to be in the 7th only. Everything else falls into place as long as you keep that in the 7th position. Ken, what's your thoughts?
Yeah, well, in what I do, ICD-10 does not play a major component. It can, in my clinical reviews, what's technically in the business termed a tier 3 report, it does come into play. But I'm not making auditing determinations. It's more of a documentation purpose. But just to kind of pivot slightly, I think, John, you'd mentioned about obstacles, and in a more broad sense, I think one of the major obstacles is illegible or poorly written medical records. And if you want to take the corollary on that, I'll jump back in a minute, but if you want to take the corollary to that, it's also note cloning. So let's
EMRs. Oh my gosh.
Right. So let's start with the issue of illegibility. This is a common theme across not necessarily orthopedics, okay? Because most orthopedic practices, I would say the bulk of them, are all electronic medical records. So this is not really an issue. They're very well versed in documentation and what it takes to get to, whatever level they want to be at. But it becomes more of an issue, say, with an anesthesia log, where you've got an anesthesiologist who, instead of, writing across through an anesthesia start time, takes his pen and starts circling over a time. And that makes it a little bit more difficult for me to give an accurate anesthesia duration time and then in assigning time units. Same thing goes with physical therapy. It's sometimes hard to determine the total time units because, as we all know, 15 plus 8 is 23, and 23 gets you to the second unit. So, these are all issues that, the providers, they just sometimes don't document it. It makes it a much more challenging situation to evaluate their bills when, if they bill $300 for therapeutic exercises, but they just write in their thing, handwritten, therapeutic exercises were performed, see flow sheet. So, we really need to continue the education of providers. I think it's paramount. And Jen, you talked about the clinical documentation. It goes way beyond just orthopedics.
Oh, yeah.
These providers really need to have sit downs, and so that they can improve their document. Look, it's not just for what I do. Medicare and the OIG are watching. So, if you want to put it from that perspective and take it outside the realm of personal injury, be my guest. But, that is another major obstacle when it comes to these issues.
I'll give you 2 more examples of how this affects documentation. So for years, I tried to tell my physician, okay, I'm not allowed to do consistent with. I'm not allowed to do anything that's maybe, because my guidelines say no. In the outpatient world, prophy, you have to tell us that it's definitive. Otherwise, it's a symptom. So consistent with a meniscal tear without evidence of meniscal tear is not a meniscal tear. I'm not putting on a claim form. Now, I have to search the documentation to find anything that is truly current on that for that day. And then later, once the MRI comes back and you confirm it's a meniscus tear, then I can put that most likely on their surgery, documentation, right? And some surgeons have told me, well, with an instance of rheumatoid arthritis, I didn't diagnose the patient with that. But is it important? Does it affect your clinical judgment when you see the patient? Why am I coding M06.9 on every single patient when you just wrote RA? Do you not have records from the rheumatologist telling you their lab values, knowing what body parts affected, what other factors are involved? So I get out the book and I say, these are the options. Do you have any of this information? Do you think any of this information is important? Because it's not just about getting paid. It's about the next physician that sees them that needs a full picture of what's going on with them. We are at an all-time high with duplicative services. We have the reason that authorization companies or insurance companies don't want to approve authorizations is because it's overutilization. You have 10 different doctors ordering the same MRI when they could just talk to each other, and then that wouldn't happen. So it's not just for coding and billing. It is for clearly understand your patient, and then the next person that sees them clearly understands your patient. Those are 2 examples that I think of.
Can I add one that's one of my big pet peeves is? Your orthopedist should know left and right.
I know.
They need the document left and right.
I really hope so.
Don't submit a claim with like an unspecified limb. No.
And you don't have to. It's usually in the note, and we're not tied to what we used to be. We can pull the laterality from anywhere in the note now. ICD-10 says we can. So it's most likely in there somewhere. Now, if it's not in there at all, then we have a problem. But usually it's in there. You have the data.
Or if it's wrong, because I've seen this.
Yeah.
The orthopedist is facing the patient. Their left is the patient right. Sometimes there's some kind of cross connection, like there's some kind of like disconnect. Like they're looking at him face to face and they say, well, the left leg is their right, but they mix it up.
And it's easy to do because you're seeing so many patients and the brain works in weird ways. So it's up to us as coders and billers to hopefully help them catch those things. And that's why attention to detail is a quality that every coder needs to have.
Yep.
Absolutely.
All right. So we did have a question related to ambulance stuff, but non-emergency transfer. I don't know if that's something that we're able to answer. It's about a Florida Medicaid fee schedules. I think the best way to answer that.
Yes.
Yeah, I think that's something that you just have to look up on that Florida, New Jersey website. They should have some kind of posting for the S code for then what ambulance codes are usually like. I think they're like
they're the HCPCS code.
Yeah.
I stay far away from ambulance. I stay far away.
A0100 is the code. And it's typically used to transport, indigent patients to either office visits or to an ambulatory surgery center for a procedure. They can't get there. They don't have the means to do it. But, the public files that are available in Florida, and I'm sure on their website, will give you information.
Yeah.
All right, so let's see if we have anything else in here that's askable. But I know there's a lot of topics on orthopedic coding and guidelines that you should just read up on. I know the orthopedic section has its own dedicated rules that sometimes don't appear anywhere else in the IC10 or in the CPT. There's a lot of things related to there's a lot of rules related to how you can treat when there is a fracture. And
fracture
when
care. We had a recent update in 23 for that, 22 or 23, but also the NCCI. So chapter 4 of the Medicare, the NCCI manual is your friend. Read it. There's some very specific things in there about shoulder scopes, knee scopes, very important stuff. And then, of course, your guidelines are your friend. And then also there's the casting part, because you can choose, right, if you want to itemize and just do E&M codes, or if you want to build a fracture care global code,
right,
you can't build a cast. It's included. Now you can maybe, it does allow you to reimburse for maybe a replacement cast, or maybe you weren't the one that originally did it, and then you have to do that casting. Like there's rules like that. So there's so many nuances. And so your guidelines are there, but also you have your payers, right? You have to know how they view it. They don't all agree with AMA CPT. They don't all agree. You may have a HCPCS code versus that replaces a CPT code for Medicare.
Right.
So you got to know.
Yeah. All right. I know this is a headache, and I love giving out headaches, but Modifier 54, 55, 56.
Oh my. Yeah. I don't know. Do you deal with that a lot, Ken?
Was that?
Read them off to me again, John. I got to click my brain.
54 is preoperative care only. Modifier 55 is a surgical care only. 56 is postoperative care only. So there's ownership of the rights. So this is something that if you're working for an orthopedic, occasionally the patient gets transferred to you from
the ER.
Right. Mm-hmm. Or to another state, they move, and you're getting transferring to another doctor. Right.
It's communication is what it is. Yeah.
Yeah, I mean, this is not something that I see on a frequent basis. I can tell you that from a usual and customary standpoint, the databases don't really break out for the use of these modifiers. It's really either the global or not, and that's kind of what it is. Now, Medicare, I will tell you from my understanding, is that you have to submit documentation. It's just like a discontinued procedure. You have to send in the record of when and why you discontinued a procedure, and then they're going to prorate that fee. So, I think Medicare is probably, they don't specifically say what they're going to pay, but they have a better guideline, if you will, in demanding, medical records to say what was being done and why. Jen, do you have any comment on that?
Yeah, no, I mean, this is one of the things I educate a lot on. I have recently, since the update came out on that, with the communication with the ER physicians, because it's about who did the actual treatment, who actually treated the fracture, who gets the billet. And then also there's that continuity of care. Like if you're not doing the postoperative care, obviously, as the ER doc, you don't get the full package, because someone's got to get paid for that part of it. So you have to have good communication. Now, that was always an issue in the past. And when these guidelines came out and revised, there was a lot of touchy people, like, what should I do? But really, it's just get on the phone, call the hospital, have a meeting, and get together and find out a process so that your orthopedic surgeon and your ER physicians can work together. So you both can get paid what you're supposed to get paid. So we don't have any compliance issues here. So it's about communication and follow through. So, and then you have payers maybe that don't like those modifiers. So maybe you're in a situation where you have to figure that out, where who really did the actual treatment, and then maybe the next physician is going to bill E&M. So it really depends on the payer if they accept that breakup of procedures, or if they want you to bill differently.
Okay. So I know we've been over the hour mark, so let's kind of see if we can wrap this up. So one of the things I'd like to ask, and these kind of web sessions are geared toward kind of informing people that might want to do orthopedics, whether or not this is for them. So Last question. What do you love about orthopedics and what do you hate? And what are some things that people might want to know if they're going to consider taking up this new medical specialty? What are some of the things that you would say as a last minute remark?
I love orthopedics. I mean, like I've always been fascinated with the bones and joints, and it was one of the specialties I really wanted to get into from the start. But it wasn't easy. It was an overnight thing. Like I developed my love over time. So there's not anything I could say like the reason why I love it. I've just been doing it the longest, and I'm fascinated every day. There's something new to discover, something new to learn, and so because it touches so many areas of the body, even though it's just bones and joints, it's from head to toe. So there's so many things. There's bones, there's joints, there's muscles, tendons. There's so many things, and so there's the podiatry aspect, there's physical therapy, there's pain management. Like there's so much, and you're never bored. I don't think. I guess if I had to pick something I hate, I hate the needless denials from the payers. That is what I hate. The authorization process. The roadblocks that our physicians have to go through to get an MRI, that they know the patient needs. They have to wait 4 weeks to get their surgery when the physician knew all along they needed it, and they just have to wait several weeks to get the MRI. To me, it's a roadblock for patient care.
And you, Dr. Ken?
Yeah, well, look, I've been in this for many years prior to becoming a coder. I'm a coder now, 6 years. So, it didn't just start 6 years ago. I've been doing orthopedic-based work for well over 30 years now, so it's a total love relationship when it comes to full circle. Look, the work that I do, I equate to trying to solve a puzzle. Really, what we're doing is we're reading operative reports and verifying that the bills and the codes that these doctors and these practices and these facilities are utilizing are correct. And our goal is to make sure that they're doing it properly. So it blends, what I do blends less of a CPC, and I'm not saying that you shouldn't have it, but it really blends the aspects of the COSC credential as well as the CPMA credential. So I'm auditing, and I'm also using my experience in the form of the COSC. So I'm in solving a puzzle, and then determining pricing and recommendations, and then coming up with a report that is handed across the table. And there's really nothing that I hate about it. I enjoy it so much. I enjoy the company I work with. I enjoy the people I work with. We all are very professional, and we all care about working toward bettering healthcare and trying our best. And that's what it boils down to. Look, if you're not happy in what you do, you shouldn't be doing it. And if you're happy in what you do, you'll never work another day in your life. So this is kind of where I'm at in my life. I'm very pleased with working in orthopedics. If you're interested in doing this, it is a worthwhile area of medicine to take up, because there's so much that is there. And just to add on to what you were saying, Jen, let's not forget about skin. Skin is another big part of orthopedics too. How many people have we seen who step on a nail, or who have a foot infection, or sustain a skin laceration, or a fish hook, a foreign body. There's so much that.
Well, podiatry sees it a lot. Wound care, the wound care and podiatry.
Wound care, ulcers, diabetes. There's so much that this field touches that it is so vast, and there's so many opportunities that you can do in
there's
this.
DME, guys. There's DME. I forgot about DME.
Exactly.
Yeah.
There's a lot of deep tissue codes that are in the 20,000 section of CPT. It's orthopedic stuff. It's not muscle. It's not bone. It's the in between. But it's
you have your medicine codes. You have radiology. You've got labs too. If you build some of those, every single almost every section has something. Even if it's like, you have orthopedic related things with other body parts. That come into that. So you just, there's so much. I can't even begin to discuss it. So, but yeah, it's been wonderful talking about my love tonight. I love orthopedics, so always happy to jump on and talk about it.
All right, so I do want to wrap it up, but I want to thank Jen McNamara. Now, Jen's got a practice consortium coming up soon. I know she wants to plug real quick.
Oh, sure. Well, I have the Practice Management Symposium coming up on February 16th. If you go to my page, Healthcare Inspired, also my personal page, you'll see lots on there. And then coming up in July, we do have the Orthopedic Summit coming back. It comes every year in the summer in July. So we have some great speakers. Sean Weiss is coming back. We'll have Terry Fletcher, some big names, the ones you're always used to. Jessica Burke will be there. And if Ken is willing to come back, we'd love to have him. We're in the beginning stages of planning the speakers. So I'll reach out to you.
And there's another name I'm going to mention in a little bit. Let's go to Ken, Dr. Ken Rosenstock. I like to put him on here. He's also a medical coding expert at ExamWorks, which when I first heard them, I thought they were like Cliff Notes, like an exam writing company. Not what they are. They're more of, like he said, a personal injury motor vehicle kind of auditing firm. But if you're interested in that kind of work, I think they're nationwide, right?
Yeah, so ExamWorks in the realm of what I do has two divisions. Our East Coast division is in Mount Laurel, New Jersey, and our West Coast division is based in California. I'm based in New Jersey. Our company is, seeking coders. We do advertise on Indeed. If you are interested and you do want to put in a request to come on board, there's a screening process that goes on, and you can just look on Indeed and find us under Mount Laurel, and it'll give you the information and how to apply.
All right.
Excellent.
And I am, as always, John Biskowski. I am the intern at Differential Coding Services, www.differentialcodingservices.com. Website is kind of lean at the moment, but it's getting better. We're improving. So next week, we have another one of the Practice Management Consortium people, Miss Vanessa Moldovan, is going to be speaking on billing, another broad category that we're going to touch on the overall aspect of. And we got a couple other coders that are going to be joining us, Miss Melinda, and there's another Jennifer, not Jennifer McNamara, but below, but there is Miss Melinda and Miss Jennifer will be joining to talk about billing, and I'll post about this tonight. But I also am looking for some more people. So if you want to join as a panelist and you work in a certain area, shoot us a message. Let us know what you do, and we'll talk it out, because I'm always looking for good, inspirational coders, billers, employees, prospective experts, people that want to talk about their job and can offer the enthusiasm that others want to see. We want to see it, and we want to put you up here. Send me an email. So I do want to see you all next week, and I do thank you for joining us. But have a wonderful Monday night.
Yeah. Have a good one, guys. Bye.
Good night.
Thank you.